Boleh kita mula, Doktor? Unmute mic.
Okay, Assalamualaikum and very good morning to all. Selamat Hari Raya. So welcome to the annual and weekly CPC of the medical faculty. This time is actually our turn, the pediatric departments. We will share with you an interesting case. We'll start with our presenter will be Dr. Mac, our senior registrar in pediatrics, and subsequently Dr. Norazlin Kamal Nor, our developmental pediatrician, will actually go through the case and also moderate the whole session. And then we have an input from our Professor Madya, Dr. Faizah, who's our radiologist, and subsequently from Professor Madya, Dr. Wong In Ping, that will be our pathologist. So without much further ado, I think we'll start with Dr. Mac to actually start with the whole thing. Mac.
Good morning to the professors, doctors, and my friends. I'm Magdalene, going to present on the CPC today with the topic of Doctor, my child hasn't been acting like himself. So I start with the history. This is a 10-year-old Malay boy with autism spectrum disorder, presented to emergency department with sudden onset of reduced consciousness, right-sided hemiparesis, and unequal pupil size. He has history of abnormal behavior for the past 2 months. Not interested in going out to play in the afternoon, appear anxious and afraid to leave the house, deterioration of school performance, grades from A to C or D. He has associated with frontal headache and vomiting for 1 month, and the headache worsened 4 days prior to presentation. He was referred to child and adolescent psychiatrist after seeking treatment for altered behavior soon after symptoms onset. He was diagnosed with anxiety and depression secondary to pubertal changes and started on antidepressants. He was diagnosed with Asperger syndrome, a form of autism spectrum disorder, at the age of 5 years old by a private pediatrician. He has limited social and communicative skills, one-way conversation, limited to his interests, cars, and dinosaurs. He has fleeting eye contact with people other than his parents and siblings. He also has abnormal behaviors, restricted interests and activities, limited socialization and communication. He obsessed with spinning wheels and arranging cars in a line repetitively. For the birth history, he was born term at 38 weeks via elective caesar with the birth weight of 3.5 kg at Hospital Pantai Cheras. Mother is 33 years old, had 4 previous history of miscarriages. The mother has no any pregnancy-induced hypertension, no gestational diabetic mellitus, no complications in pregnancy. He's born in a good condition. Postnatally, patient was well. No significant issues during the first year of life and the early development reportedly according to the age. At emergency department, patient appeared to be drowsy, hard to arouse, and was unable to open eyes or recognize his parents. His vital signs with the normal blood pressure of BP 114/55, tachycardia 140 beats per minute, respiratory at 23, saturation of 98%, air fever 37 degrees Celsius, and his GCS is low, 8/15, E2, V1, and M5. He had unequal pupils with the right 2 mm, left 4 mm, and left side is not reactive to the light. And the neurological examination revealed right-sided hemiparesis, reduced power right upper and lower limbs with hypotonia of both upper and lower limbs, right-sided, and also hyperreflexia of the right lower limb. He has no dysmorphic features or neurocutaneous stigmata. The anthropometric measurements of weight and height were at 75th to 90th percentile. So in summary, it's a 10-year-old boy with underlying Asperger syndrome with abnormal behavior for 2 months, worsening headache and vomiting for 1 month, came in with low GCS, unequal pupil with right-sided hemiparesis. So my provisional diagnosis will be intracranial tumor. The point score is the patient had worsening headache and vomiting, change in behaviors, deterioration in school performances, and right hemiparesis. We'd like to get further history about the red flags of headache. How is the onset of the headache? Is it rapid onset? Is it thunderclaps headache? Worsening with positional changes of Valsalva maneuver? Any neurological symptoms like body weakness or visual disturbances? Constitutional symptoms like loss of appetite, loss of weight for the past 3 months of duration, and any family history of malignancy, for example, in von Hippel-Lindau syndrome with autosomal dominant inheritance, where tendency to have family history of brain malignancy. We'd like to perform a full neurological examination and also fundoscopy to look for papilloedema. And the investigation we'd like to do will be CT brain and also beta-CG and alpha-fetoprotein. The next will be differential diagnosis for this patient will be arteriovenous malformation. The point score is the patient had change in behavior, headache, vomiting, deterioration in school performances, is it because of seizures, and the sudden deterioration with right hemiparesis. We'd like to further ask about any history of seizures, body weakness prior to that, and family history of vascular malformation. In hereditary hemorrhagic telangiectasia, it can have this abnormal malformation. And physical examination would like to look for vascular malformation over the face and any of the body, and investigation will be MRI brain, MRA, and MRV. The next differential we would like to consider will be Moya-Moya disease because of change in behavior, headache, vomiting, deterioration in school performances, and right-sided hemiparesis. The points again, most of the time, Moya-Moya disease presented with transient ischemic attack. And for the history, we'd like to ask any history of seizures, any associated syndromes like vasculitis or immunological condition in grave disease or SLE, hematological problem, renal abnormality, or syndromes like neurofibromatosis, Marfan syndrome, tuberous sclerosis. And positive history of family history because Moya-Moya disease is associated with genetic association with the RFN213 gene association. And investigation will be MRI brain, MRA, and MRB. The last differential diagnosis we'd like to consider would be autoimmune encephalitis. The point score is this patient had change in behavior as well as deterioration in cognitive function in the school performances. The points against will be this patient presented with right hemiparesis. The further history will be like to ask for any psychiatric manifestation like hallucination, bizarre behavior, sleep disorders, seizures, dyskinetic movement, language dysfunction, or viral-like symptoms that preceded with the behavior changes, HSV infections, sometimes will lead to seroconversion to become autoimmune encephalitis as well. And in the physical examination, to look for any autonomic instability. For an investigation, we'd like to send for CSF biochemistry for pleocytosis, CSF for NMDR antibody, and also EEG. So overall, the investigation we'd like to perform will be full blood count to look for anemia that due to bleeding, renal profile and VBG because of dehydration as the patient is unwell for the past 3 months of duration, the coagulation profile to look for any coagulability, beta-CG alpha-fetoprotein for germ cell tumor, antiphospholipid screening, lumbar puncture look for biochemistry, and CSF for NMDR antibody. For the imaging, we'd like to send for CT brain and also MRI brain with MRA and MRV. Thank you.
All right, thank you, Dr. Mac. I would like to call upon Dr. Azlin to actually go through the results and the other query by Dr. Magdalene.
Thank you, Dr. Juriza. These are the results for the full blood count, renal profile, coagulation profile, venous blood gas, and also the CSF from the lumbar puncture. For the imaging result, we will be going to Associate Professor Dr. Faizah for her input.
Before that, Dr. Mike would like to comment on the results first. Anything that you want? Before Dr. Faizah goes through the radiology image.
So for the investigation result, shows that normal full blood count of HP 13, white cell 22, and platelet of 458. Abnormal renal profile with hypernatremia with a sodium 146. It can be due to dehydration as the patient is unwell for the past 1 month vomiting. And the other differential can be due to overzealous fluid resuscitation during the initial part. It can be due to that. The coagulation profile was normal. The VBG shows that uncompensated metabolic acidosis can be due to dehydration. There will be high glucose, high protein in the CSF with 7,531 and low glucose 1.37. The CSF FME appearance blood stain, blood past cell, bacteria, yeast cell, all are new, and the CSF culture no growth after 5 days. So from the lumbar puncture result CSF, I can conclude that this can be a traumatic tap because appearance of blood stain with high protein, and the low glucose can be due to the blood clot that stimulate the glycolysis event or meningeal inflammation that impaired the glucose diffusion. So therefore, it would appear like this, and eventually the culture is no growth. So likely is a traumatic tap.
Okay. Okay, then we get Prof. Faizah to actually comment on the radiological aspect.
Dr. Juriza, there's question in the Q&A for Mac. I think Prof Wong asked question. Mac, do you want to answer where is the lesion to account for the hemiparesis?
The lesion, because the patient presented with right-sided hemiparesis, so most of the time, I think the lesion will be over the left-sided region. Likely the frontal and parietal that affect the cognitive function in the frontal and the memory, because deterioration in the school performances will be the parietal lobe. So it will be around that area of left-sided.
Would the traumatic tap give rise to such high CSF?
Yes, it can be, it will give rise to that kind of picture in the lumbar puncture CSF result, or the other differential, it can be due to intracranial bleeding with that pictures, or it can be due to infection like HSV infection with blood-stained CSF.
Shall I?
Okay, Prof. Faizah.
Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. I would like to say thank you very much to the pediatric department for inviting me to participate in this CPC. So I hope you guys can see my slide. So yeah, as what Mac has requested, so the patient has had the ACT brain at the time of presentation. Because of the acute presentation, then we did a plain and we performed a plain CT brain first. But when we look at the findings, then we proceeded with the post-contrast at the same time. So if you look at the CT brain, then obviously we can actually see a mass-like lesion in the region of the left basal ganglia, including the left frontal as well as left temporal. And it has actually caused quite a significant mass effect, whereby there is evidence of midline shift. It has compressing the left lateral ventricle to the contralateral side, and there is also compression to the third ventricle, and thus the contralateral lateral ventricle is also dilated. There's also evidence to suggest, cerebral edema, because there is an increase in effacement of the sulci. So just to recap the findings, we can actually see there is a midline shift, okay, to the contralateral side because of the mass effect, quite a significant one. And then we'll be seeing there's a subconsign herniation because the mass has pushed the all the midline structures to the contralateral. There's also effacement of the basal cistern here in the final cistern, and then there's also effacement in the region of the prepontine cistern. So this is the pre-contrast study that I showed earlier. And then on post-contrast, we are not seeing a significant enhancement of the mass, but literally whatever the vessel that has been located at the center, like in this case, the subependymal vein and the central venous vein has been also pushed to the contralateral side. Okay, so just for the medical student, I think the intracranial mass effect findings would be variable, but those are the things that you need to see because it will indicate some alarm to the then the midline shift, as I showed earlier, sulcal effacement, and the ipsilateral ventricle would be reduced and the contralateral ventricle will be enlarged because the third ventricle is being compressed. Okay, so again, the midline shift, and then this is the by right, the normal sulci, the CSF that goes in between the sulcus, within the sulcus, which should be normal, but if you lost that sulcation, then that means that there's effacement, and which it indicates evidence of seborrheic edema. Okay, so also there's also an effaced basal cistern, which also indicate that the mass has gone down. Now, beside those findings, other findings that related to mass effect will include a brain herniation. If there is a craniectomy, then the brain will try to, go and get towards the lower pressure, which is at the outside. So there is an external herniation. And this patient, and I've actually showed earlier, she had a subfalcine herniation whereby there is evidence of mass effect and it goes to the contralateral side. And there's also a transtemporal herniation if there's a mass in the supratentorial. And if the mass is majorly causing mass effect to the temporal lobe, then there will be a uncal herniation because uncal is actually located at the middle aspect of the temporal lobe. And if there's mass effect, a significant one, and it can go and towards the infratentorial. Another finding which is a bit more alarming is when there is a tonsillar herniation. This can happen if there is posterior fossa mass or posterior fossa mass effect, but if it is a very significant supratentorial mass effect, it can actually cause a tonsillar herniation and it compressing on the brainstem that whereby the cardiac as well as the respiratory centers is being compromised. Okay, patient can be obtunded then. So this is the post-operative CT. So our neurosurgeon has managed to remove some of the leaf mass, and it's majorly in the region of the left temporal lobe as well as a bit at the basal ganglia. So you the one in the yellow box, you can actually see the previous one before the operation. So you can see there is reduction in the mass effect. As evidence, you can see a bit of the ipsilateral ventricle, and the third ventricle is now is being you can actually see it. So that means less mass effect has been happening in this patient. And if you see in the contralateral high parietal, you can see the CSF in the sulcus again compared to the previous one, which already effaced. Okay, so the MRI was done a few days later. So it further characterize the mass as well as it indicates where exactly the mass is by location. And you can see this is the mass that actually occupy the whole left basal ganglia. The mass actually had this blooming artifact, what we call it on the SWI sequence, whereby it indicates there's some evidence of hemorrhage within it. So this is the ADC, just to show how there is a restricted diffusion minimally in the wall, that there is some necrosis at that region of the wall of the mass. And this is the T1 and T1 post contrast. You can see that's not much difference. There's no significant enhancement of the mass on post gadolinium on this image. So just to show you the T2, so that's how it looks like, and the T2 corona is how you're looking at the patient from the front, and you can see the lateral ventricle is now started to open because of the reduce in the mass effect. Okay, so this is only one slide on the common intra-exit tumors in pediatrics. The approach is basically location, and location, because if you have a supratentorial mass, like in our case, the common intra-exit tumor in pediatric will be astrocytoma, or this is a PNET, okay, and we have also a pleomorphic xanthroastro, whereby there's quite a huge cystic lesion with neural nodules, and then this is in a neonates, whereby there's a ganglioglioma, diffuse infantile ganglioglioma, or a more cortical-based lesion in the supratentorial, which is the DNET, and commonly it will cause location in the region of the hippocampus. So if you have an infartentorial mass, then the differential diagnosis would be a juvenile pilocytic astro. Again, the character is that it is predominantly cystic with nodules. If it is in the midline of this infratentorial within the port ventricle, then your differential will go for a medulloblastoma. And if it's a bit more eccentric towards the paramidline and it's extending to the Lashka, then your differential will be an ependymoma. And of course, age also is the main factor in approaching an pediatric tumor lesion. So this is the MRI baseline. However, 6 months later, you can actually see that the mass has actually gone and infiltrating on the corpus callosum, and it goes to the contralateral side, very, very diffusely infiltrative. So this is a high-grade glioma, and this what it is at 8 months later, whereby it has actually seedling into the ventricles of the contralateral side as well. So this patient actually had some not so common intra-axial tumor of a pediatrics. We lump it in a high-grade glioma, and it is, all this grade 3 and grade 4 GBM is included in this group. High mutational burden, okay, and however, there's no definitive MR features can differentiate between a low grade versus a high grade, but evidence of differentiation or irregular and very infiltrative margins with edema may suggest HGG over LGG, but yet, HP is still definitive, and the pattern and intensity of the contract enhancement would not correlate with the tumor grading. So like in this case, we don't have much contrast enhancement, but very infiltrative, and that's why we go for a high-grade glioma. So thank you very much.
Thank you, Prof. Faizah. So, Dr. Mac, so what would be your diagnosis now, and why do you think the most likely diagnosis in this patient?
So the diagnosis of this patient would be the 10-year-old boy with underlying Asperger syndrome with left temporal intracranial tumor, most likely will be glioblastoma. Then maybe looking for HPE for
Okay, right. So I'll call upon Dr. Azlin to continue with the progress of the patient.
Thank you. This patient was intubated and ventilated in emergency department, and he underwent emergency craniotomy and debunking of the tumor on the same day. Intraoperative findings were that there was a large left temporoparietal intraparenchymal tumor with necrotic areas and intralesional hemorrhage, which was soft to firm in consistency. Dr. Meg, what would you what further information would you like to know based on this?
would like to know about what is the histopathological diagnosis for that?
Okay. For that, we'd like to invite Associate Professor Dr. Wong Lin Peng from Department of Pathology to discuss HPE findings.
Okay, thank you. Allow me to share the screen. Right. Very good morning to everybody. I would like to thank the Pediatric Department for inviting me to participate in this CPC. So I'd like to talk about the histopathological finding in this patient. So what we receive is multiple fragments of grayish tissue measuring 35 mm in aggregate diameters. And this tissue is soft in consistency, and we entirely submit the specimen in 2 blocks. Okay, so this is what we see in low magnification. Basically, there's more of the tumor tissue. So this is just to highlight this. There's multiple fragments of tumor tissue in other areas as well, in contrast to adjacent unremarkable brain tissue. So we can appreciate here is relatively very hypercellular as compared to the normal counterpart. Okay, so this is what we can derive in low magnification with areas of hemorrhage, you can appreciate here. And there's vascular proliferation at the end here, right? At higher magnification, you can see this is a tumor tissue, very hypercellular with all infiltrated by all of them are tumor cells. So we can appreciate there's some multinucleated, giant-looking tumor cells here. And at this magnification itself, we can see there's 2 mitoses already. So at higher magnification, this is where we will appreciate the morphology of the tumor cells. This is where we can see the tumor cells. All of them are actually tumor cells. It displays a very hyperchromatic irregular nuclei with inconspicuous nuclei. Basically, we cannot see any nuclei in this case because of the 2 hyperchromatic looking nuclei. And you can see mitotic figures here. This is an atypical form of mitosis in the background of the glial tissue. So we can see this is most likely a glial tumor by H&E itself. So this is in another area we can see this is microvascular proliferation. Basically, it shows that the vessels actually is actively proliferating as well, forming multi-layers. Somebody called it a glomeruloid microvascular proliferation because it looks like a renal. When you can imagine the histology of the renal, it looks almost like the same, like a balls of vessels, right? So you can see this vessels also is rather abnormal. It consists of 3 layers of cells. Usually we don't see that in a normal brain tissue. So in this area, we can conclude that this microvascular proliferation seen is highly suggestive of a high-grade gliomas. Okay, in another area, we can see geographical necrosis is consistent with the intraoperative findings. So you can see this is a very nice tumor necrosis here, palisaded by the tumor nucleus of the tumor. So it can actually similar to this kiwi. Like, so when you see geographical necrosis, so you can imagine you can see a kiwi, cross-section of the kiwi. So we will do, usually we will do further immunohistochemistry to confirm our finding. We will not just stop there. So GFAP is a very common immunohistochemistry that we will do for brain tumor. Basically is to highlight the glial origin of the tumors. So no doubt in this case, so it's very wall-to-wall positive stains. All the nucleus actually stains up for GFAP. So it gives a very nice membrane staining in this case. Also, we will do Ki67 is a proliferative index markers for tumors. So you can appreciate here, usually we will look under a very high magnification at 400, and then we count the cells over the tumor cells, how many tumor cells actually positive. So this is about 30 to 40% by eyeballing. So if you want really objective ways of counting it, you can actually use the image analysis. So this is typical of a high-grade gliomas, right? So with the histological finding of having nuclear that is highly atypical, with mitotic figures and also microvascular proliferation and together with geographical necrosis. So we'll conclude that this is consistent with the glioblastoma, WHO grade 4. Okay, with that, I thank you very much.
Thank you, Prof. Wong. Before we actually go to Mike, can you answer the Prof. Wong's questions on the Q&A?
Sure.
Okay, Prof. asked about the CT findings to the level. So the highest protein level due to the factors that cause the protein to build out, or it can be due to the building itself, the tumor itself can cause the high protein.
Okay, so based on all the findings that you got, what will be your final diagnosis in this patient?
So the final diagnosis for this patient is volume underlying exposure syndrome with grade 4 glioblastoma with massive effect on the obstructive hypertrophic.
So can you correlate all the clinical findings and the pathological findings in this patient? How does this whole thing happen?
So this patient presented with abnormal behavior for the past 2 months of duration and also anxiety. So it can be due to there's a enlarging brain tumor in the brain that affect the cognitive function and as well as the memory in the parietal lobe that cause deterioration in the school performances. But having said that, it can be due to this patient is 10 years old, pivotal changes with psychiatric association with underlying autism spectrum disorder. But 2 months later on, this patient had new symptoms of headache and vomiting. So I would think that more like organic causes rather than the psychiatric association. This will be the risk ICP sign, which got worsened and progressive as the day goes. And when presentation presented with low GCS with unequal pupils in right side hemiparesis, likely due to the brain tumor with the mass effect that caused coning effect. Yeah.
Dr. Azri, you would like to continue and wrap up the case?
Thank you, Dr. Juriza. Let me share my screen. I'd like to talk about the patient's progress. After the first day of the operation, patient developed signs of Cushing reflex and cerebral edema with bradycardia and hypertension, and he required mannitol and saline. Repeat CT brain, as mentioned by Prof. Faizah, showed the post-operative changes of reducing degree of midline shift, but there was still fullness on the right side of the foramen magnum, indicating mild tonsillar herniation. On the 30th of December, he had removal of skull flap for decompression, and it was found that the brain was still very tight. The dura was removed, the brain became pulsatile, and EVD insertion was not able to be performed. He showed some slow progress following operation, and MRI brain showed post-op changes with similar degree of mass effect as showed earlier. Following the diagnosis with glioblastoma grade 4, he was commenced on HIT-HGG 2007 protocol and started on radiotherapy with concomitant temozolomide chemotherapy for 6 weeks for a total of 54 GY, and MRI post-chemo and radiotherapy showed extensive leptomeningeal metastases. He continued to show slow progress over the next few months and developed cystic encephalomalacia at the left cerebellum. The disease became more progressive and he developed increasing tumor size and numbers, crossing the midline with extensive leptomeningeal metastases and cranial nerve involvement. He underwent recraniectomy with tumor debulking again in August of 2018, but he continued to deteriorate with recurrent seizures and bulging of the craniectomy site. Further imaging showed disease progression, and the family were counseled that the prognosis was poor and further surgical intervention would not be curative. The patient was referred to the palliative team and the family decided on supportive end-of-life care. The patient was unfortunately pronounced dead on 30th of September 2018, less than a year after diagnosis. So in this case, which is a rare presentation of malignancies that occurred in a child with autism spectrum disorder, we wanted to highlight autism spectrum disorders and certain comorbidities that we do not see as frequently, but which are still very important comorbidities because, as you can see, this actually led to a very serious condition and mortality. So background on autism spectrum disorder. This is a persistent neurodevelopmental disorder with impairments in two main areas, which is communication and socialization, as well as distinctive behaviors, including repetitive, restricted interests and activities. It tends to present heterogeneously, meaning they don't, all children with autism don't always look the same. And there are also overlapping comorbidities, or what we can call ASD phenotypes or subphenotypes. In the past 4 decades, the prevalence has been increasing. It's up to 1 in 59 to 68 currently, or WHO reports it as about 1 to 2% worldwide in good prevalence studies. Male to female ratios shows that there is a prevalence in males compared to females, and also that there is a difference in how ASD present compared between males and females, whereby girls with ASD tend to present with increased severity with, for example, coexisting intellectual disability and epilepsy. As I mentioned before, autism prevalence has been increasing quite markedly in the past 3 to 4 decades, currently with prevalence of about 1 to 2% worldwide. The exact reasons are not known fully. However, we do appreciate that there is greater awareness, and there's been a change in diagnosis from children who, for example, would have been diagnosed with intellectual disability to now being diagnosed more precisely with autism spectrum disorder, and also a change in diagnostification, whereby now we use a new version, which is the DSM-5, which means that even people with mild degrees of autism can be diagnosed. So autisms can be considered a variety of impairments. As I mentioned before, the main areas are in communication and social interaction, as well as interests, behaviors, and activities which are restricted and repetitive. But in addition to that, children with autism present with a wide variety of abnormalities in terms of medical comorbidities, psychiatric comorbidities, developmental and behavioral comorbidities. For example, as shown here, children with autism often present with gastrointestinal disturbance, difficulties with feeding, sleep disturbance, seizures, growth abnormalities, and sometimes even rare ones like malignancies. The exact cause of autism spectrum disorder is not yet known, but we do recognize certain associations. For example, increased predominance in male gender, increasing parental age being associated with risk of ASD, and also that ASD is associated in a small percentage, about 1 in 10, with medical conditions such as Fragile X, tuberous sclerosis, Rett syndrome, and phenylketonuria. Overall, it is seen now that risk factors can be divided into genetic, environmental, and epigenetic factors, in which is a combination of those. So genetic factors have been shown, whereby sibling recurrence risk is estimated to be between 2 to 18.7%. Nowadays, it's considered that if you have one child with autism, the risk of another child having autism is about 1 in 5. And also that we see that first-degree relatives of those with autism are more likely to display milder versions of autistic phenotypes, although they might not actually fulfill the diagnosis of autism itself. In terms of environmental factors, it's also been seen that, as mentioned before, increasing parental age has shown an association. And in addition, there are toxicants and infections that have shown an association with increased risk of ASD. And ASD is thought of as a disease of early life, meaning that the prenatal window is very important. And we suspect that either the condition has occurred even at the moment of conception or during the gestation itself. So epigenetic factors explain some of these combination of genetic and environmental factors and how they might interact. So we know that autism is heritable. In fact, the heritability of autism is almost 50%, which is one of the highest percentage of heritabilities in neurodevelopmental disorders. So in terms of genetics in autism, the majority of specific genetic findings to date are rare, de novo, and likely in gene disrupting regions, meaning that it's not usually in one gene, it's multiple genes, maybe multiple genes working together or multiple genes that interact with the environment. Although each rare variant is of low recurrence, genes with multiple hits across cases are implicated. Autism genes are not typically specific to ASD, but can be more general to neurodevelopmental, such as intellectual disability, and psychiatric conditions such as schizophrenia. Across implicated genes, major biological domains are implicated, for example, abnormalities in synaptic functioning and chromatin remodeling. So what about ASD malignancies and genetics? Although a study in 2010 showed that overall, there is no increased risk of ASD in children with diagnosed with oncological malignancies compared to the general population. But we see that there are several candidate ASD loci that have been related to tumor development. So there is an increased risk of malignancy in ASD in children with specific genes. And in particular, the genes that have been implicated are the P10 gene and other tumor suppressor genes such as EXT1. Autism has also been associated with abnormal growth, including macrocephaly, obesity, and tall stature. And ASD with macrocephaly has been correlated with this P10 gene abnormalities, which is a gene phosphatase tensin homolog. There is a potential clinical utility of mutation detection for cancer screening and early detection in children with macrocephaly and ASD. Studies have shown that P10 gene mutations occur in children with ASD, although rarely. A study in 2007 found a prevalence of 1 to 2%. And in 2012, a combination of case reports reported a total of 24 patients with P10 gene mutations in those with ASD, macrocephaly, and clinical features of hematoma tumor syndromes. A paper by Klein et al. In 2013 also showed that these novel P10 mutations have been identified at least in 2 loci at 6q23.2 and 10q24.32. And a paper in 2017 by Ito et al. Showed that conditional knockout of P10 in mouse brain caused abnormalities in neurons with synaptic dysfunction, which has been recognized as a biological pathway previously described in ASD. So the P10, or the phosphatase and tensin homolog deleted on chromosome 10, codes for a protein, phosphatase and tensin homolog. P10 is a tumor suppressor gene, and it's an important regulator of neural connectivity and plasticity. Somatic mutations of P10 have been reported in glioblastoma multiforme, endometrial carcinomas, and also in tumor syndromes like Cowden syndrome, Banayan-Riley-Ruvalcaba, and Proteus syndrome. Our patient, of course, was diagnosed with glioblastoma multiforme. And P10 hematoma tumor syndrome shows an increased risk of specific malignancies, including breast, thyroid, renal, and endometrial cancers. In addition, benign tumors can also occur, and which are more common, and can range from skin papules to vascular anomalies. There is a broad range of neurodevelopmental effects associated with PHTS, from normal development to severe autism disorder and intellectual disability. So what we wanted to highlight in this case, in this rather rare case, is that ASD occurs with comorbidities, such as neurodevelopmental, psychiatric, and medical. In our case, the child had a change in behavior. And because children with ASD at the cusp of becoming a teenager could have an increased risk of psychiatric conditions, especially in a child who is high functioning. And this child was diagnosed with Asperger, which is a form of usually high functioning autism. It was thought that the change in behavior was due to depression and anxiety. However, when considering that this child presented with a constellation of symptoms, including raised intracranial pressure, whereby he had headache and vomiting for 1 month, we need to consider even rare comorbidities such as malignancy, which is what this patient ended up having. So really our take-home message is that clinicians need to be aware that children with ASD have symptoms that change in behavior may not just have change in behavior because of neurodevelopmental issues or psychiatric issues, but could also have organic problems like brain tumors. And especially for students, remember when there are signs showing, for example, in this case, raised intracranial pressure, really think about organic causes, right? In this particular case, we also wanted to highlight that in children with ASD, there is this association with P10 gene mutation, especially in children who have large heads or macrocephaly. And therefore, perhaps in the future or even now, when seeing children with ASD and macrocephaly, it's important to think about whether we can actually send for specific investigations to actually look for this association, like the P10 gene mutation, so that early screening can be performed, and perhaps children like this can be detected to have coexisting problems before it gets to a point where a mortality can't be avoided. So that's our presentation for today.
Thank you, Norazlin. So I just wondered, did we manage to send a P10 for this patient?
No, we didn't. Unfortunately, the patient actually passed on before that could be sent. But it is possible to actually send that through a private lab here. They can send basically a sequence analysis for specific genes. In this case, for the either malignancy genes such as a P10.
And how much will it cost?
It costs about $250 US.
Okay. So any questions from the others? There's one Q&A. Dr. Pak, you want to answer that?
The one question will be